Hello, and welcome back to post-concussion syndrome. We are now on video 3, talking about exercise testing. I'm going to give a quick review from video 1 and 2, and then we're going to get right into the Buffalo Concussion Treadmill test, referred to as the BCTT. So in video 1, I talked about the energy crisis as well as recovery time, specifically the set recovery time for acute concussion, as well as highlighting the importance that there is no specific recovery time for PCS. Here we have graphically illustrated the Rowan's Law, where if there is a hit, must stop and sit out, especially if there are any of the symptoms. In video 2, we highlighted that early reporting is important, and that was done with the study from the University of Florida, NCAA athletes. If we remember from that video, the 7-day mark had 70% of the athletes return to play if they reported their symptoms immediately. If they delayed their reporting, then it took 70 days for 100% of that group to return to play. So it's important to report your symptoms immediately. Exercise can avoid deconditioning, and deconditioning can cause autonomic deregulation, as well as that disproportionate response to CO2. The flowchart we're looking at here is for those with persistent symptoms that they should run through the BCTT, depending on their symptoms or no symptoms. Either we know they need an exercise protocol, or we should look at vestibular ocular or cervicogenic PCS. So this is the instruction manual for the BCTT from John Letty, Mohammed Haider, and Barry Willer. This is really important for you if you are looking at running this test. Have a look through this instruction manual so you can see all the things that I'm highlighting here, but in full detail in their manual. One of the things we're looking at, this is the caution point. The BCTT alone should not be used to make a diagnosis of a concussion. That's reasonable because though at this point, you already have persistent symptoms if you were looking to run someone through this. Also, that it is a supplementary test. Well, of course, we need a complete history and physical examination. Rule out any red flags or any underlying causes and injury. So what are the requirements? Well, of course, you need a treadmill for a treadmill test. You also need a heart rate monitor, and it's recommended to have a chart to track heart rate, VAS, RPE, as well as symptoms. The instruction manual recommends having 2 trained practitioners. While 2 trained practitioners are very important, it's likely that this test needs 1 on site, but it's important to consider with increasing telehealth options that there may not be practitioners on site. So you may need to learn how to run this test virtually and have other people present supporting the test. Contraindications. So of course, if their heart is not operating well or their lungs are not operating well, you cannot run this test. So please take a couple moments to look through the contraindications listed on the instruction manual. The VAS, this is a visual analog scale. Definitely recommended to have visually present when you're running this test. And what we're looking at, it's a 0 to 10 scale. And then of course, there's nifty graphics here to make it easier. You can run this test if a patient already has symptoms. Say, for example, they have a headache and their headache is a 3 out of 10. If during the course of the test, their headache increases, and they feel it's only a minor increase, it goes to 4, that's reasonable. If they have a new symptom, then it cannot go just to 4. It has to go higher. So there's 1 point for a new symptom and 1 point for a symptom increase. So let's say again, they have a headache of 3, their headache gets worse and they feel some dizziness, it has to at least increase to a 5. The stopping criteria for VAS is 3 or more point increase on this scale. Our RPE, rating of perceived exertion, it's a scale from 6 to 20, and very silly from 6 to 20. But when you have it color coded, and as well as the explanations on the side, makes it a little bit simpler to get the necessary answer from your patient or client. So starting at 6 are 0 exertion, going all the way to 20 are maximal exertion. Our stopping criteria for RPE is above 17. This is that red range. So very hard, you can no longer talk, extremely hard, and maximal exertion. All these red ranges. So the pass or exercise prescription, if they get to an RPE of 17 or greater without symptom exacerbation, that's a pass. If they get to 90% of their heart rate max, so age predicted heart rate max, again, without symptom exacerbation, that's a pass. If their VAS increases by 3 or more, so that means they're having symptoms and the symptoms are getting worse or they're getting new symptoms, that is not a pass, and they need an exercise prescription, generally set at 90%, well, less than 90% of their heart rate threshold. So using that recommended chart where you're keeping track of heart rate, VAS, RPE, as well as symptoms, you can then make a note when they hit that heart rate threshold and the symptom, the VAS, increases by 3 or more. Now their exercise prescription is based on that threshold. There's a lot of evidence supporting exercise. This was a meta-analysis done with 11 studies. All of these green arrows had positive outcomes showing that they either decrease symptom severity or decrease time in return to play. One showed moderate conclusions, but we want to make note that this test did vigorous exercise. Remember, we're not talking about vigorous exercise. We are talking about an exercise prescription that below 90% of their heart rate threshold. And this test alone is generally a walking test. So this is not vigorous exercise. Limitations, of course, it's important to note. These were small sample sizes. Sometimes statistical significance was not noted. Vigorous exercise was symptomatic. Of course, this is reasonable. And all the people in the study were generally under 30 years of age and mainly an athletic population. So either they were athletes or they generally played recreational sports. So depending on what population you're treating, it's important to consider that. So to quickly review, we talked about or highlighted some of the important things from video 1 and 2. We went over the BCTT and a lot of the important pieces of information there. What's to note is that the instruction manual is available online. This video, again, is just educational, so none of this is medical advice. I'm just here to support and share information. And to re-highlight this flowchart, for those with persistent symptoms, they should go on the BCTT. If their symptoms are exacerbated, then they need exercise protocol. So that's daily and below their heart rate threshold. If they don't have symptoms, then they need vestibular ocular PCS or cervicogenic PCS, which has its own specific treatment, which I'm going to talk about in the next video. I'm also going to highlight some symptoms. We're going to compare and contrast these two types of, these two subtypes, and also talk about some treatment considerations specifically for these subtypes. Thank you so much for listening. Look forward to seeing everyone soon.